Warm welcome to all of you, friends, on this Friday evening. We have two important exam cases for the evening. One is a case of obstructive jaundice, the other one is a Phyllodes tumor of the breast. The Phyllodes tumor case is kindly contributed by Professor Hitesh Andaria, sir, and the obstructive jaundice case is kindly contributed by Dr. Hemant Natyal from Jolly Grant. So we'll have the Phyllodes tumor case as the first case. Dr. Zeel, please switch on your video, share your PowerPoint. And we have very eminent faculty who are joining us this evening. Our own faculty, Kanna sir, Hitesh sir, and Rajiv Sahay sir. And we have Dr. Nikhil Talwar, who is joining us for the first time from the Lady Harding Medical College. Professor Tarun Kalra will be shortly joining. Professor Shilpa is still tied up with the transplant. I wish he could join. And we have Professor Maria Johnson Anthony, the professor and head of the surgical gastroenterology at Government Salem Medical College, joining us. We warmly welcome all the esteemed faculty for the evening. So I wish the students have an very active deliberation. Faculty, please take over. Dr. Zeel, please introduce yourself, your unit chief, and uh, start your presentation. Good evening, Khanna sir and Abhay sir. Welcome, sir.
Good evening. Good evening.
Dr. Zeel, go to the first slide and start, ma.
Yes. Good evening, sir. Am I audible?
You are perfect, Khanna. Good luck to you.
Okay. Thank you, sir. Good evening, faculties. I am Dr. Zeel Bhatt, third year general surgery resident from Narendra Modi Medical College, Ahmedabad. My PG teacher is Dr. Hitesh Andaria, sir. Now, this is the case of a 44-year-old unmarried female patient, a homemaker residing at Ahmedabad, came to the hospital with chief complaint of lump in the right breast since last 1 month. The patient was relatively asymptomatic 1 month ago, after which she noticed a lump in the right breast, which was insidious in onset with a size of approximately 3 by 3 centimeter, rapidly increasing up to present size. The lump is not associated with pain or nipple discharge. Patient has no history of fever, no history of ulceration over the breast, no history of trauma to the breast. Patient has no history of loss of appetite or weight, no history of back pain, no any abdominal complaints, no history of chest pain, cough or hemoptysis. Patient has a history of incision and drainage of right breast abscess 1.5 years ago. No history of radiation exposure in the past and no history of intake of any oral contraceptive pills. Patient has no any comorbidities. Personal history. Now patient consumes a mixed diet, has normal bowel and bladder habits, normal sleep pattern and unaltered appetite. There is no history of any addictions like smoking or alcohol. Menstrual and obstetric history. The patient has attained menarche at 15 years of age. She is unmarried, nulli gravida, and has regular menstrual cycles. Family history. No history of breast cancer in first or second degree relatives, and no history of any ovarian, prostatic cancer, colorectal cancer, or pancreatic cancer in the family. My case summary is a 44-year-old female patient with chief complaint of a painless lump in the right breast, rapidly increasing in size in 1 month, not associated with any pain or discharge, and no any systemic complaints.
Okay. Dr. Z, let's go back to your. What do you think is your, sorry, what is your differential by history?
Actually, sir, this is a elderly female plus a rapidly progressive lump.
44 is not elderly. What's an elderly female? What age would we call an elderly elderly lady? 44, she could still be menstruating.
Yes, sir. She is menstruating.
So you call her elderly?
No, sir. Perimenopausal.
So what age is elderly?
So more than 50 years.
Nowadays, 50 years. Nowadays, it's more than 75 years. It's elderly. Do you get me?
Yes.
So don't put these epithets on each. Do you get me? It's not right. Okay. So 44-year lady, unmarried.
Yes.
Lump. Right breast. for last month, 1 month, not since last month, for 1 month.
Yes.
So just go back to your first leg. What's the rate of growth of this lump?
Sir, it was initially 3 by 3 centimeter in size, and at present it is 10 by 10 centimeter in size.
And no other symptoms.
No,
Let's
no
go to
other
your
symptom.
first. Dr. Bhatt, let's go to your first slide, please. Okay, next slide, please. Next slide, please. Okay. So she doesn't have any symptoms related to metastasis.
No, sir.
Okay. No features of malignancy anywhere.
No, sir.
Okay. So now what do you think? 44-year lady with no other symptoms such a large increase in 1 month.
Sir, I'll still have a suspicion of malignancy because the lump is very rapidly progressive, and it could be even a giant fibroadenoma or a phyllodes tumor, looking at the history up till now.
Okay.
Any other positive points in your history, madam? Saying it is malignancy lump?
No, sir.
No
Painless
positive.
lump. It is a painless lump, so it could be a malignant.
Meanwhile, I will just check out my progress. So we have something.
In the family history, you are only looking for the cancer breast, isn't it?
Yes, sir.
Let me just.
And the fibroadenoma and the Phyllodes tumor, they can run in families.
Phyllodes tumor can run in family, sir.
Fibroadenoma,
Fibroadenoma, no.
yes, they can also run in families, you know.
Okay.
So when you are writing the family history here, you are not to only tell about the cancer breast, but no history of breast problem in the family, okay?
Okay, sir.
I'm your employee, Prashant, who is a senior.
Now, if you think such a rapidly growing tumor is there, can it be a sarcoma of the breast?
Yes, sir, it
Is
can.
your differential diagnosis?
MacBook, everything. You download it in your laptop and you.
It can be, sir.
Will be your reaction, Prashant, and everyone. All these people, top executives. What is your reaction if an employee like me do this to you? See this.
What is your age? 44.
Now let's say
Yes, sir.
Prashant will call
44.
me.
What is common stage for Phyllodes tumor?
Sir, 40 to 50 years of age.
Will ask me, Hardik, how do I just see engineering?
What is pathological features of Phyllodes tumor?
Interactive. I made a
Sir, it is pathological features.
Microscopic.
Sir, it has a bosselated appearance.
Microscopic.
Microscopic. Okay, sir. It is a leaf-like appearance with clefts and stromal hyperplasia, and with some cystic areas and some solid areas.
Thinking right. Prashant, do I deserve a salary? I can promote. Unmute yourself and let me know.
Yeah, Hardik, it is an amazing presentation.
What is the other name of the Phyllodes tumor?
Sir, cystosarcoma phyllodes or serocystic disease of Brody.
Thank you so much, sir.
Okay.
Appreciate it.
I'm not thinking.
How the patients of Phyllodes tumor will present?
I can. Like you
Sorry,
can make.
sir, I could not hear you.
How the patients of Phyllodes tumor will present? Or what is the
Sir,
clinical manifestation in case of Phyllodes tumor?
so the patient will present with a huge lump, which will be having an uneven surface, lobulated surface, and with variable consistency. And it is usually painless.
Awesome, really awesome.
Is there involvement of the skin?
Sir, the skin is tense and shiny, and there may be dilated prominent veins.
No. I will misconcept. I will clarify that communication as well. Okay?
Someone is interfering. Please mute
Somebody is-
everybody. Those who are not active, please mute.
Why to impress boss when you can become your own boss? Why not? Why not? Why not? Now.
Now, if it ulcerates from the skin, then can you differentiate between that whether it is because of the malignancy or because of the Phyllodes tumor?
Sir, we need to check for the mobility of the lump. If it is mobile,
Okay, we will
it
come
is
on in the examination part. We will come there. Okay. Yeah, we will
okay.
come in the examination part. Yeah.
What
So
about
pressure necrosis is one of the
Dr.
component of the Phyllodes tumor clinical presentation.
Yes, sir.
Dr.
Pressure
Var.
necrosis can be present.
That's what I'm expecting from you.
Yes.
Okay.
And history? History?
Okay, Dr. Seal,
Yes, sir.
you asked about the history of nipple discharge.
Yes, sir. There is no nipple discharge.
All right. So if it was breast malignancy, what sort of a nipple discharge would you expect?
Sir, blood stained.
And if it was a fibrocystic disease,
Sir, it would be a serous discharge.
why does blood-stained discharge occur in a breast malignancy?
Any other cause for blood discharge?
Sir, ductectasia can also have blood stained discharge.
Any other than ductectasia?
Sir, intraductal papillomas.
So how do you differentiate between discharge due to papilloma and discharge due to the malignancy?
Sir, there would be duct infiltration in case of malignancy. So there would be
No. What is characteristics of discharge in case of the duct papilloma and what is characteristic of discharge in case of the malignancy? Both will present as a bloody discharge.
Yes, sir.
So what is characteristic feature? Fresh blood is seen in which condition and altered blood is seen in which condition?
मेरे फोन से वो ज्वाइन भी करवा दे हाँ कहना सर नहीं मिल रहा तो
Seal.
Yes, sir.
इसमें ना
Which type of discharge will see in case of papilloma?
Sir,
Very basic question. Fresh blood is seen in papilloma and altered blood is in malignancy. Why there is altered blood in case of malignancy? In PG exam, most of the time, examiner will catch in these points. These are the basic points.
Yes, sir.
Okay, what is periductal mastitis?
So periductal mastitis is the inflammation of ducts.
डॉट केस है अच्छा ये इसको ज्वाइन करा दे यहाँ जो चार्जिंग पे लगा दे लगा के नोट और डॉक्टर टम्पा को बोल के सर हम पहुंच गए हैं आज तो बोल 10 मिनट्स लगे
Sorry for the inconvenience, friends. Audio is muted. Please go ahead, sir.
What is periductal mastitis, Jill?
Sir, periductal mastitis is the inflammation of ducts and it will present with a slit-like nipple retraction.
What is pathophysiology?
It can be due to, sir,
tuberculosis. बताना तो चाहिए ना आपने कहा भेज देगा
What can be the different causes of nipple retraction?
पूछा था कल जो है हमको याद है
It
तो
can be
कहने वाले थे
periductal mastitis. There will be a slit-like nipple retraction. In case of carcinoma, there will be a circumferential nipple retraction.
And any other
Which
causes?
retraction is the clinically significant?
Sorry, sir?
Which retraction is the clinically significant?
Sir, circumferential.
No. Any other classification of retraction? Depending upon onset?
No, sir, I don't know.
Recent retraction of the nipple is a suggestion of the clinical malignancy.
Yes, sir.
So a long-standing retraction, if it is there, It can either be congenital and most likely it will be benign.
Okay,
So
sir.
what you're looking at is a recent onset nipple retraction. What can be the other causes of nipple retraction?
Sir.
You said malignancy, you said periductal mastitis.
Yes, sir. Sir, it can be present in phyllodes as well. Usually not seen, but if it is very large, then it can be present.
Another cause is congenital. The first thing you should always say when you're asked about causes of nipple retraction, first thing is congenital
Yes, sir.
inversion of the nipple. Then come the pathological causes.
Okay, sir.
What type of nipple you see in case of duct ectasia? What is the characteristic of the nipple in case of duct ectasia?
Sir, it is
There will be partial retraction will be there with a transverse slit. That
yes.
is very characteristic of that. That the nipple has got the transverse slit is there. That is very characteristic of the duct ectasia. And in case of duct ectasia, you do not get the hemorrhagic fluid. Okay, it is a serosanguinous type of the fluid which comes out, not the hemorrhagic fluid in the duct ectasia.
Yes, sir.
You can go on the examination now, please.
Yes, sir.
Dr. Zil, I asked about history. Will you ask of recurrence? That means patient might have been operated 2-3 times or even more times. That is also important for phyllodes
Yes,
because
sir.
it's a locally recurring tumor,
Locally
right?
recurrent. Yes, sir.
So why did she have the breast abscess? You know, she is unmarried.
Sir, she had a history of trauma, blunt trauma to the breast 1.5 years ago.
But you never mentioned any trauma. You said there is no history of trauma.
So there is no history at a present. She had when she had 1.5 years ago breast abscess. At that time, there was history of trauma.
Would a breast abscess occur due to trauma?
Sir, actually, she said that there was some hemorrhagic material, probably a hematoma, but she had no, sir, documents were not available, whether it was a breast abscess or a hematoma.
Was that swelling or a hematoma aspirated, followed by infection?
No, sir, incision and drainage was done. Aspiration was not done.
So, no, what I'm asking is if an aspiration was done of a hematoma, that aspiration itself can cause seeding of the infection
Yes, sir.
from the skin into the hematoma. Was it that?
No, sir.
But unlikely a 44-year-old female would get a breast abscess straight up. It's very unlikely.
Yes, sir.
What is traumatic fat necrosis?
Sir, blunt trauma to the breast, it causes traumatic fat necrosis.
What is the importance of that? Can fat necrosis mimic like the malignancy?
Yes, sir, it can.
Yeah, it's a
Dr.
very
Zeal,
important
is it just
diagnosis.
suppose someone gets one blow on the breast, will it cause traumatic fat necrosis?
Sir, it can, but it is not necessary.
No, it will not. What is the kind of trauma which causes traumatic fat necrosis? It is chronic trauma. So if people, it usually happens in women who have got large floppy breasts, and when they sleep, the breast gets squashed between the elbow and the chest wall, and there's this chronic trauma every day, and that leads to chronic traumatic fat necrosis, not a blow or a trauma on the breast straight away. Do you get
Okay.
me?
Yes, sir.
Yeah.
Right, we can move to the examination now.
Yes, sir. So, general examination. The patient was examined in a well-lit room after obtaining informed consent. The patient is conscious, cooperative, well-oriented to time, place, and person. She has an average build. She is afebrile. No pallor, icterus, clubbing, cyanosis, edema, or generalized lymphadenopathy. So, the patient's vitals are pulse is 78 per minute, blood pressure of 140 by 90 mm Hg in right arm. Respiratory rate is 18 per minute. Her height is 160 centimeter and weight 70 kg. Her BMI is 27.3. Now coming to local examination, inspection was done after proper exposure from neck till waist. The patient was examined with arms by side, arms raised above the head, hands over waist, bending forwards and in supine position. So on inspection, there is bilateral breast asymmetry. The right breast is enlarged as compared to left breast and it lies at a slightly lower position as compared to the left one. Right areola is significantly enlarged as compared to left side. The right nipple appears cracked, less everted in comparison to left side, and there is no visible discharge. The surface appears lobulated and skin overlying the breast is stretched and shiny with dilated veins seen, and there is no evidence of any ulceration, dimpling, puckering, or a pudgy orange appearance. And the left breast appears visibly normal. There is no axillary or supraclavicular fullness seen. Now, patient is examined with arms raised above the head and the lump becomes more prominent. There is no dimpling, puckering, or pudgy orange appearance. With leaning forward, the right breast falls more as compared to the left one. And hands, while examining the patient with hands over the hip, the lump becomes more prominent. This is the image, sir. The right nipple lies at a slightly lower level as compared to the left, and the right breast is grossly enlarged. And
Move
on
the
the
slide. Move the slide.
yes, sir.
Now you can continue the discussion because
Yes,
otherwise
sir.
it will be blocked on YouTube.
Yes. And sir, on the right side image, we can see that the overlying surface is lobulated. It has irregular surface, uneven surface.
You
Then,
can toggle the slide once again if examiner wants.
yes, sir.
All right, continue.
Yes, sir. Now all the
Continue with the
inspectory
palpation.
all inspectory findings were confirmed on palpation. On examining the right breast, there is no warmth, no tenderness. A single lump of approximately 10 by 10 centimeter involving lower quadrants. It is involving all quadrants, all four quadrants, more in the lower quadrants. It has a variegated consistency and a bosselated surface, and the lump moves along with the breast tissue. There is no fixated to skin or chest wall. The right nipple is cracked with no nipple discharge. There are no lymph nodes palpable in bilateral axilla or supraclavicular region. The left breast is normal. Systemic examination. The heart CVS examination is normal. The heart sounds are present. Bilateral air entry clear. No focal neurological deficit. And on examination of abdomen, there is no palpable lump or organomegaly. So my case summary is a 42-year-old female patient with complaint of painless lump in the right breast since 1 month, initially 3 by 3 centimeter and rapidly progressing to the current size, not associated with pain or any nipple discharge. There are no systemic symptoms or no significant family history. The general examination is normal. And on local examination, there is a lump in the right breast, which is involving all four quadrants with overlying skin, shiny, and dilated veins over it. The lump has a variegated appearance. It is non-tender, mobile, with a bosselated surface, approximately 10 by 10 centimeter in size, with no skin or chest wall involvement and no axillary or cervical lymphadenopathy. So my provisional diagnosis is a Phyllodes tumor of the right breast with a suspicion of malignancy.
Dr. Zeal,
Yes, sir.
both phyllodes tumor and suspicion of malignancy are usually a pathological diagnosis.
Yes, sir.
Why are you saying suspicion of malignancy?
So because it is rapidly progressing, plus
Phyllodes is a rapidly progressive condition. It may be benign, it may be malignant, it may be indeterminate.
yes, sir.
So this suspicion of malignancy, you've got nothing to relate to it. Unless you take that variegation of the consistency may or may not.
Yes, sir.
So in when you have a phyllodes tumor, you got to be very guarded in your differential. You get me?
Yes, sir.
Because phyllodes is one thing where even triple assessment may be wrong,
Yes, sir.
right? So okay, I say this is virginal hypertrophy of the breast. It can be on one breast, virginal
Yes, sir.
hypertrophy. How will you prove that it's wrong?
So because it has a bosselated surface plus variegated consistency, and it is rapidly progressing with no lymph node involvement, and it is mobile.
Look, the only thing which can differentiate from virginal hypertrophy of the breast and phyllodes is the age factor. VH is seen only in young women,
Young women.
while
Yes.
phyllodes can be seen in either of the ages.
Yes, sir.
Virginal hypertrophy is usually not seen. It may be persistent. She might be having it since childhood or since puberty, but it persists. So it can't be for 1 month, like you say, in your
Yes.
case. So that's the clinching factor to say that it's not virginal hypertrophy of the breast.
Yes, sir.
And there is a mass.
Yes.
Okay, let's go to your examination. Look, regional examination. Yeah. So, is the lump fixed to anything, any structure, to the skin, to the breast
No, sir.
tissue, to the chest wall, to
No,
the
sir.
pec major?
What about
Okay,
skin?
No, sir.
how do you know? What about how do you
It
know
is
it's
not
fixed to
fixed to
the
skin.
How do you know it's a 10 centimeter tumor?
Yes, sir.
How do you know that it's not fixed to the skin?
Sir, it so there are no
Suppose
skin
yeah.
involvement like dimpling or puckering.
No, look, dimpling, puckering, these are all extraneous. They're not important in malignancy. They don't change the staging.
Yes, sir.
Dimpling will not change the staging. Puckering will not change the staging. Skin involvement does.
Yes, sir.
So dimpling, puckering, these are just MBBS, just to make sure that you know how to examine the breast.
Yes, sir.
As a surgeon, we are not interested in dimpling and puckering. Okay.
Yes, sir.
So now, how do you tell me about how do you test for the fixity to the skin?
Sir, by holding the lump between the thumb and the index finger.
Mhm.
So we actually check for whether the skin is pinchable or not.
Look, pinchability, if the lump is
What
fixed to
you
one
better?
side, you can pinch the skin on the other side, right?
Yes,
So a
sir.
better way is that if the lump, does the skin move along with it or not,
Yes, sir.
right?
Yes.
Okay. Now let's go to your breast tissue. Can you determine whether it's fixed to the breast tissue?
Sir.
Such a large lump,
Yes,
hardly
sir.
any breast tissue left. You can't demonstrate.
Not demonstrate.
So you can't do it.
Yes, sir.
It's obvious. Most of the breast tissue is compressed to the periphery. Now fixity to the pec major.
So that is confirmed by examining the patient and hands over the waist.
Mhm. Leaning forwards. If the lump doesn't fall forward, It may be
Yes,
fixed to the
it is
pec
fixed to
major
the pectoralis.
or to the chest wall. It
Yes,
can be fixed to the either of the two. Now you can distinguish whether it's fixed to the pec major or to the chest wall
yes,
by that contraction of the pec major kind of things.
yes, sir.
Okay, next slide. Next slide. Next slide. Okay. Suppose the lump was 10 centimeter by 5 centimeters.
Yes, sir.
What dimension would be the most important dimension?
So the greatest dimension.
So we write 10 by 5 for a visual this thing, but the largest size
Yes,
is the most important
most
size.
important.
You can just write a 10 centimeter size tumor, largest 10 centimeter size tumor is sufficient.
Yes, sir.
Okay, bosselated surface. Okay, why do you say what do you mean by bosselated and why is it bosselated?
So bosselated surface means it is uneven and it is due to the
Okay. A
What is
phyllodes
nodular
tumor
surface? Jill, what is nodular surface?
so
okay, answer. What is a nodule? A small lump,
yes, sir.
right?
Yes,
So
sir.
there are multiple small lumps. The lump, your whole tissue will feel nodular.
Nodular.
But if if the surface is undulating, then it's bosselated. You got one. What is bosselated? If there is a trauma on your forehead, there's a big swelling
Yes,
here.
yes,
That's bosselated, right?
yes.
So why is it bosselated? Why are phyllodes tumor bosselated?
So because of stromal hyperplasia and
Right, it's got both stromal and epithelial tissue.
yes, sir.
So the stromal tissue is the one which makes it bosselated.
One it makes
And the,
both.
and the epithelial tissue is the one which makes it leaf-like.
Yes, sir.
Right. Okay, next slide. Nipple cracked with no nipple discharge. What do you mean by cracked?
So in the image, the nipple appears cracked. It is usually not seen with phyllodes. It is seen with Paget's disease of the nipple.
Okay, what is Paget's disease?
So it is the ductal carcinoma in situ of the breast.
Is it? It can't be infiltrative carcinoma, ductal carcinoma of the breast. Look, Paget's is nothing but ductal carcinoma which is close to the skin.
Yes, sir.
Most distal in the duct. So the tumor cells, they grow and they creep out of the duct and they infiltrate the surrounding tissue, the skin. Do you get me?
Yes, sir.
So they destroy the nipple,
Yes.
right? So no, I mean my problem is that why have you said cracked nipple? Does it help in your diagnosis
No, sir.
or does it cause help in your differential? It doesn't.
No, sir.
It creates confusion.
Yes, sir.
It puts up questions which are difficult to answer.
Yes, sir.
So in the exam, you should not put any description which you can't explain.
Yes, sir.
You get me? It is not
Yes.
important. Now that you put it, someone will ask you. Now you say Paget's. There'll be some
Yes.
examiner who must have done a PhD on Paget's, and he'll crack you down.
Yes, sir.
He'll rub your nose to the grindstone on Paget's. Do you get me? So
Yes.
never do that in the exam.
Yes, sir.
Next slide. Next. Okay. So anyone? Dr. Tarwar. So, Dr. Nikhil.
Yes, sir.
Please.
So let me ask you a very basic question. What is the basic principle for palpation of the breast? What is the basic method?
Sir,
Suppose.
it is done with the Pulp of fingers, and usually it is done by dial clock method. That is from outside to inside. We move.
Okay. You move in a clockwise direction or you move in an anti-clockwise direction?
Sir, clockwise direction.
Sure.
Yes, sir.
May I just interject? Dr.
Sir.
Zeal, your
Yes, sir.
answer would be, I will palpate it in whichever way so that I make sure that I don't miss any quadrant.
Yes, sir.
Yes.
Clockwise, anti-clockwise, spoke fashion, centrifugal, centripetal, they're all methods so that you don't miss any quadrant,
Any quadrant.
any
Yes,
portion.
sir.
You get me? Yeah.
So you
Yes.
make a convention like you start from 12 o'clock, move clockwise, 1, 2, 3 to 11 o'clock. You cover the entire circumference
Yes, sir.
and then come radially inwards. And then finally you examine the retroareolar region.
Yes, sir.
Okay, so why do you say it is a cystosarcoma of phyllodes? What can be your other differential diagnosis?
Sir, it could be a giant fibroadenoma.
So why not a giant fibroadenoma as the first diagnosis? A fibroadenoma is much more commoner than a phyllodes.
So, considering the consistency and the bosselated surface, plus considering the age of the patient, fibroadenoma is usually common in younger females, 15 to 35 years of age. And
The age would not be a criteria.
yes,
If you ask me, I'll say that the rapid increase in size
yes, sir.
would go in favor of a phyllodes.
Yes, sir.
Fibroadenoma will not increase in size so rapidly. A phyllodes would.
Yes, sir.
And why not a malignant?
Notes-
Sir.
Yeah, please carry on. Yeah.
Yes, sir, please. You were asking something, sir.
What are the various lymph nodes you examine in the patient with a breast lump?
So, axillary lymph nodes,
Yes.
then supraclavicular lymph nodes,
Yes.
then infraclavicular.
Yes. Any other lymph node? You also examine for the internal memory lymph
Internal
nodes.
mammary lymph nodes. Yes.
So how do you examine for the internal memory lymph nodes? Okay, you can see the fullness in the parasternal area,
Yes, sir.
right? And then you percuss in that area. That area there may be the dull node may be there if the nodes are enlarged.
In the intercostal parasternal area, it will be dull.
You know what is the name of this axillary lymph nodes when we say it is level 1, level 2, level 3?
Sorry, sir.
The axillary lymph nodes can be divided into 3 levels.
Yes,
Level
sir.
1, level 2, level 3.
Yes, sir.
You know what is level 1, level 2, level 3?
Yes, sir.
What is
What is
that?
the level one?
Sir, level 1 is below and lateral to the pectoralis minor. Level 2 is in front and behind the pectoralis minor. And level 3 lymph nodes are.
Level 2 is behind the pectoralis
Level?
minor.
Yes, sir.
Level
In
2
front
is
and
behind
behind?
the pectoralis minor, not in front.
Yes, sir. Behind. And level 3 is above and medial to the pectoralis minor.
And
So level
this
3 is also
classification
known
is
as, sorry, level 3 is also known as
Sir, Rotter's node.
rotor node is different.
no, 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 no. What is Rotter's node? Now you say
is-
something and then you have to answer that. So what is Rotter's node?
Sir, between the pectoralis major and the minor.
So Rotter's is
Pectoral.
interpectoral.
Yes, sir.
Rotter's is interpectoral. Level 3 is apical.
Yes.
This is goes by the name of the Birch, BERG, Birch classification of the level 1, level 2, level 3.
Okay.
You know what is the name of the sentinel lymph node? Who has given this sentinel lymph node by his name?
Sir.
That is Guiliano. Okay, Guiliano is the person.
Okay.
You can call it for the sentinel lymph nodes. What are the things you examine in the abdomen in a patient of suspected like breast cancer? What are the things you can see in the abdomen?
Sir, ascites may be present.
Okay.
Then, so hepatomegaly may be present.
Okay.
Then,
Other than this,
Or what else you get?
then
Female patient, premenopausal.
sir, already given answer.
Anything in the female genitalia?
sir, ovarian cancer can be.
What is that called as?
Sir, Krukenberg's tumor.
Zuckerberg tumor. Okay. Something behind the uterus, in front of the rectum.
So, bladder, urinary bladder involvement.
Urinary bladder is in front of that, and it is not in between the uterus and the rectum. Pouch Douglas,
Yes, sir.
what can be there? Rectal shelf, bloomer shelf. You know what is that?
Yes. Actually,
What is that?
What is bloomer shell?
sir,
Metastatic deposit in which pouch?
Okay, in the pouch of Douglas, है ना?
yes, sir.
Total one.
Yes. Anything over the umbilicus?
Sir,
Any
Any
nodule
nodule?
over that?
sorry, sir.
Any nodule over the umbilicus?
Sir, Sister Joseph nodules.
Sister Mary Joseph nodule.
Yes.
Okay, so these are the various things you can examine in the abdominal in a suspected case of CA breast.
Yes, sir.
What are the things you can find in exams on the chest in suspected case of CA breast?
So, patient may have pleural effusion.
Okay.
Then,
Can have the consolidation also.
yes, sir.
So how do you differentiate between consolidation and the pleural effusion? Both will be dull on percussion.
Yes, sir.
So how will you differentiate? Clinically, can you say that whether it is pleural effusion or whether it is consolidation? You know what is vocal fragmitus?
Yes,
Have you
sir.
heard about that?
Yes, sir.
So what will be there? In which case it will be increased, in which case it will be decreased.
Sir, in pleural effusion, it will be decreased.
It's a liquid is there, so it will
Yes.
be decreased.
Yes, sir.
Consolidation is solid, so it will be increased.
Increased. Yes, sir.
Okay.
What is sentinel lymph node biopsy?
Sir, it is the first lymph node draining the tumor bearing area of the breast. And
Can you describe the technique of sentinel lymph node biopsy?
So it is usually done in the periareolar region. And
Sir, what are the types? Is it
so
only the dye which is for the sentinel lymph node or something else can be done?
no, sir. Radioactive tracers can also be used.
There you don't do any peri or anything there, na?
Yes, sir.
It is only the dye case, na? You will give the.
Yes, sir. Very well. Only that.
Mhm. Mhm.
What do you mean by sentinel lymph node? Sentinel meaning?
So first,
Similar with sentinel tag in Fisher. What does it do?
सेंटिनल का इंग्लिश मतलब क्या है?
Literal meaning.
गार्ड. गार्ड.
Guard. It guards.
yes.
It guards.
So if it is negative, the rest of the axilla is guarded.
Good. Yes, sir.
Unlikely to be affected. Okay. Okay. How do you proceed now?
Sir, I would like to go further with triple assessment.
Okay.
So
Okay.
What's that?
after completion of my clinical examination, I would like to proceed with radiological investigation.
Okay. Go on. What have you done?
Sir, I will go for a mammosonography.
Okay. How will that help you?
Sir, it will help me identify whether it is a solid lesion or a cystic lesion. And plus, it will help me differentiate from malignancy.
So you do a mammogram to differentiate between benign and malignant lump.
Yes, sir.
No, you don't. What's the basic function of a mammogram? Why do you have to get a mammogram done?
Sir,
What's the
for
basis? Go on.
a suspicion of malignancy, sir, by REDS.
Why going for straight? Why do
In
mention?
which
Take a
age group
biopsy.
will you do?
Take a biopsy. Why do you want to do a mammogram?
Sir, I want to look for any other lump which is not visible,
Exactly. Impalpable lumps.
impalpable
The
lumps.
other breast. Right?
Yes.
That's
What
why.
is age
Not
group for
because you want to.
mammography and what is age group
Sorry,
for
sir.
Not because.
sonography? What is age group for the mammography? In which age
Sir, more than 35
mammography
years.
is needed? For sonography or mammography?
For mammography.
Mammogram, sorry.
Yes, sir.
More than 40 years is mammogram. And
Yes, sir.
between 30 to 40, 35 to 40 is sonography.
Yes, sir.
Why is that? Why is that?
Sir, because in younger females, there are dense breasts, and so
Yeah.
for that mammography is inconclusive.
Why? So suppose she's 35. Can I get a mammo or not? Of course you can.
Yes, sir.
It is just that it's difficult to interpret.
Yes, sir.
There's no contraindication for it,
Yes, sir.
right? If I have a suspicion, a mammo may help. Only when the breast is very dense, it may not come up. Then what's the alternative? I have a suspicion she's got a strong family history. I want to get a baseline. Then you get an MRI done.
MRI, yes, sir.
Right. Okay. So suppose your mammoth is just a lump or a diffuse. It doesn't show anything positive. Have you got the mammo with you?
Yes, sir.
Yeah, just post it. There. What does it tell you? Just interpret
Sir,
the mammo, the film.
so there is altered architecture
Okay.
and high density.
Look, Dr. Zeel,
Yes, sir.
whenever you're looking at mammogram, just go sequentially. Look at the skin, look at the breast tissue,
Yes, sir.
look at the lump, look at the axilla.
Yes, sir.
Okay, now tell us. Anything in the skin?
No, sir.
Right. In the breast tissue?
Sir, sir,
There's just a dense area occupying most
yes,
of the
sir.
breast tissue, which is compressed.
Compressed,
Right.
yes.
Now the lump?
Sir, no any speculated or
It is
margins.
homogeneous. There's nothing you
Yes, sir,
can't see.
homogeneous.
Yeah, it's not speculated. It's not infiltrating. The
No
architecture is normal.
microcalcifications.
Can you see the axilla here? The
Yes,
one where I can't see it. Anyway, the axilla.
In which view do you see the axilla?
sir, mediolateral oblique.
Okay.
MLO. Okay. So, what does your mammo report say? What is the impression?
Sir, mammo report is suggestive of Phyllodes tumor, Byrad's
Barrett's what? Barrett's what?
3,
Dr.
sir.
Seal? Huh?
3.
Barrett's 3. What does that tell you?
That,
What's
sir,
Barrett's?
it is probably benign.
Okay. So suppose this was a 2 centimeter lump, Barrett's
Yes.
3. What would be your response? Suppose it was a 2 centimeter lump, Barrett's 3.
Yes, sir.
What would be your response?
Sir, I would go for a biopsy, true cut biopsy.
A core biopsy.
Yes, sir.
Suppose it was 1 centimeter.
Sir, I would still go for an ultrasound guided biopsy.
No. You will repeat an ultrasound after 6 months.
Okay, sir.
Barrett's 3, you got to do nothing. Unless you've got hard signs of malignancy.
Yes, sir.
There are no lymph nodes, no signs of metastasis, nothing there. You have to review the patient after 6 months with a repeat ultrasound.
Okay, sir.
Or if any signs develop. Right. So no core biopsy, no ultrasound guided, nothing.
Yes.
Okay. Yeah.
What is sonomammography?
Sir, it is mammography and ultrasonography both.
So the patient will go into two machines, isn't it? One for the sonography, another for the mammography.
Yes, sir.
Sonomammography is only for the ultrasound machine, okay?
Yes.
So you use the high resolution sonography, and that is in other terms called as the sonomammography.
Yes, sir.
Okay.
Sonomammography doesn't mean you do an ultrasound and then do a mammogram. It's
Yes.
just the whole thing is taken as such, right? Don't get confused about that.
Yes, sir.
Okay, next, what have you done?
So next I have gone for true cut biopsy.
Core biopsy.
Yes, sir.
Okay. What was the report?
Sir, it is suggestive of Phyllodes tumor with intermediate malignant potential.
Okay. Why was it posted as intermediate malignant potential? What are the characteristics of in pathology it makes it potentially malignant?
So the mitotic rate, then margins.
Margins.
Sir,
Margins seen in biopsy.
You've got a core biopsy, Dr. Bhatt.
yes, sir.
So core biopsy, what are the characteristics of one is mitotic phase, okay?
Yes, sir. Then stromal
Some
hypoplasia.
Yeah, pleomorphism.
Yes, sir. Pleomorphism.
Pleomorphism, okay, that's ATP.
Yes, sir.
Okay. Now what have you done?
Now, sir, I will go for a simple mastectomy.
Why will you go for a simple mastectomy?
So because the tumor is involving almost the entire breast, plus it is of intermediate malignant potential, so it has a chance of recurrence as well.
Okay.
So
So
instead of
just because
wide local excision,
no, is there an alternative to simple mastectomy here? Simple
sorry, sir.
mastectomy, okay, is an easy way out. You've done a simple mastectomy, and the
Yes, sir.
histopath comes out as giant fibroadenoma. Now, what do? Hold your head and sit. What have I done? I'm not saying simple mastectomy cannot be done. It is done
Yes, sir.
in large tumors like this on 10 centimeters can be done. But I'm giving an option.
Sir, wide local excision can be done.
Okay, why do you have to do a wide local excision here? And
Sir,
how wide?
sir, with a 2 centimeter margin of normal tissue.
Was that 1 centimeter? Am I wrong?
Sorry, sir.
Suppose I take, you said 2 centimeter. Suppose I take
Yes.
1 centimeter. It's very unlikely to get 2 centimeter in these large lumps. So
Yes.
suppose I take 1 centimeter or half a centimeter. Am I wrong?
No, sir.
Why? So why do you go for 2 centimeter then? Look, it is 1 centimeter margin. Why?
Yes.
Why? In fibroadenoma, we don't do 1 centimeter margin. We just take out the lump, enucleation.
No, sir.
In this in phyllodes, we have to do a wide local margin. Why?
Sir, we will check for the margins. If the margins are positive, then a re-excision can be.
No,
Cavity shave-off
my
needs to be done.
Dr. Zeal,
Yes,
my
sir.
question is in fibroadenoma,
Yes.
giant fibrinomas, we just do excision,
Yes, sir.
enucleation. In cystosarcoma phyllodes,
Yes, sir.
why do you have to do a wide local excision? You have to
Because,
take
sir,
a
it
clear mark.
has high chances of recurrence. It is locally
Why?
malignant.
Why? Because here also it's got those finger-like projections into the normal breast tissue,
Yes, sir.
which is not there in fibroadenoma,
Yes, sir.
right? Like in sarcomas, huh? Like in mixed parotid tumors, they all
Yes.
have finger-like projections.
Finger-like.
That's why you have to do a wide local excision.
Yes.
Now, suppose this is 10 centimeter. There's a high likely chance that it will reoccur. So what will you do to prevent it?
Sir, I will ask the patient to come for follow-up.
When, when does it most often recur? After how many days does it feel most common?
Sir, radiotherapy can be given.
My question is, peak sense of recurrence after how many days?
Sorry, sir, I cannot hear you.
How many days is most commonly seen to reoccur? 3 months, 6 months, 1 year, 5 years, when?
Sir, 6 months.
1 year. So they reoccur between 1.5 years, right?
Yes.
So you have to give radiotherapy. Can it give chemotherapy? Can it give chemotherapy?
Sir, you are not audible. Please switch off video so that bandwidth is increased.
Okay. Can you give chemotherapy or radiotherapy?
Sir, there is no role of chemotherapy in phyllodes tumor.
Say so. Chemo can be given.
Okay.
Not very substantial, but it does help. Hormone doesn't help. Okay. Radiotherapy does help. How much radiotherapy? How many guys? 40 to 60 grays. Okay.
Yes, sir.
Yeah. Suppose there is METs. What is so characteristic about metastasis of phyllodes from other malignant breast malignancy?
Sir, it has a hematogenous spread.
That's fine. It even the other thing. I tell you, this is the difficult one. The METs don't have any epithelial tissue in them. They just have stromal tissue.
Yes,
This is a characteristic of metastasis of phyllodes.
phyllodes.
Right. So I'm the answer. Anyone else, please? Okay.
So just one last comment about chemotherapy. I hope all of you will agree that chemotherapy has a very limited role for cystosarcoma phyllodes, and it is only recommended for metastatic disease.
Right.
It's
Agree
not like
completely.
for IDC, invasive ductal carcinoma, that you give in an adjuvant setting.
I agree completely. Radiotherapy is for
Thank
local
you.
recurrence, chemotherapy is for distant mets, but the prognosis is very poor. And if there's mets, average survival rate is not more than 2 years.
Dr. Gill, I would like you to share the gross section of these specimens for the benefit of all PGs. And we can discuss something about, because the specimens are usually asked in exams, if you have the photo.
Sir, actually,
Don't have? Okay.
sorry, sir.
What are the different types of Phyllodes tumor?
Sir, it is based on the histopathology, it is benign, borderline, or malignant.
What is the chance of recurrence in benign,
Sir,
in
it is
borderline, and in case of malignant?
approximately 10% in benign, 15 in borderline, and 20% in malignant.
So even in the benign conditions, there is chance of the recurrence
Yes,
is
sir.
there. And that is why you have to always go for the wide excision in these patients.
Yes, sir.
I think we can.
Yeah, I think we
Dr.
can
Kanagawa?
wind up now.
Yes, sir.
So please,
Sir,
Dr. Khanna, please.
I have the photograph of specimen. If everybody agrees, I'd like to share.
Yeah, please, sir, please. That would be very nice.
Jill, unshare your.
Yes, sir.
In the meantime, I'd like to tell you, see, you've done very well.
Yes.
Phyllodes tumor is basically, it's very difficult to present as such and convince everyone that because it's there's a lot of there's no findings other than the lump,
Yes, sir.
right? But in examination, I would like to tell you, just say things which you do in your wards,
Yes, sir.
right? And make sure that you know what you're talking about.
Yes, sir.
You've done very well. You've done very well. Very impressive.
Thank you, sir.
Let me try once more. Where is it? Share.
फोन पे दिखा दिया sir.
Yes, sir.
Yeah, I got it. Oh yes.
Few more also. But I think this is enough. I think this itself is a challenge, and it's very easy one if you know the
Yes, you can
pathology.
see that there's a wide margin. You can see the margin is
Yeah.
quite wide from
Yes.
the tumor on all sides. So very well done.
Very nice.
Right. Should we go to the next
Yes, sir.
candidate?
I'm trying to unshare now.
Nice presentation, Jail.
Thank you, sir.
Good luck, Dr. Zil. Zil, do you have any questions to ask faculty?
No, sir.
I
Very
think
good. Thank you very much. Yes, sir, please.
I like to add one. I like you should have considered the abscess drainage. Probably the history given was some blood clots were removed. You should have
Yes.
considered that as a recurrence. That would have added to your clinical uh, provisional diagnosis as well.
Yes.
Right?
Yes.
You should have considered that the documents, and it was really done it was done in our hospital only. It was done as evacuation of hematoma, and biopsy was not sent. That was probably the great blunder on the surgical team part. If it would have been sent for biopsy, probably she would have been given the advice of follow-up, and this much bigger recurrence would have been avoided.
So recurrence is a characteristic of phyllodes,
Yes.
Yes.
which is not there in fibroadenoma.
Sir, I tell you, I have removed, I've done simple mastectomy as a 10th surgeon of a 28-year-old lady, and she was having the first time pregnancy at that time. So I waited for second trimester. It became huge, and then I removed.
Yes.
The
So it
out
can
of
happen.
9, even 7 surgical scars are seen on that photograph.
Right.
It is that much
So that's the
notorious.
cause of cystosarcoma phyllodes.
Yes, sir.
Sir, Kannan sir, you are in mute mode, sir.
I remember one patient where I have operated for 14 times.
Oh, sir.
And ultimately she developed the sarcoma.
Oh.
So sad.
And she succumbed to that, yeah.
Mm.
So
That's why nowadays they say
phyllodes
the
tumors are
second
very,
recurrence
very
you require
notorious, very notorious, yeah.
Yes,
So
very
nowadays
notorious.
second
Professor
recurrence means
Nikhil, would you like to add something?
Sir?
Professor
No, I think
Nikhil,
we've
sir?
had a very fruitful discussion, sir. We've had a very fruitful discussion, sir. Thank you.
Thank you, sir. Thank you. Dr. Tarun Kalra? Right. Dr. Zeel, you can stay with us. You can be part of the next discussion. Dr. Saurabh?
Oh.
Dr. Saurabh Joshi?
Yes, sir.
Hemant, sir? Yes. I could see Rishabh Joshi. You are Saurabh Joshi or Rishabh Joshi, man?
Sir, Saurabh Joshi.
All right, no problem. Saurabh, please share your PowerPoint. All right. Rishabh, your PowerPoint can show. Professor Maria Johnson Anthony is joined as a specialty moderator. Faculty kindly involve him also. Dr. Maria Johnson, sir?
Yes, sir. Yes, sir. I
Yes,
am
sir.
inside.
Now we have the obstructive jaundice patient.
Okay,
Rishabh,
sir.
please answer yourself.
Rishabh, go to the full screen mode.
Yes, sir. Sir, I am in full screen.
In the
mode.
bottom center
Sir.
of your screen, you will have a green arrow which would say share.
Your name is Rishabh or Saurabh?
Sir, Saurabh.
Saurabh, okay.
There would be a green arrow at the center of your screen. If you're in the full screen mode on your laptop,
Yes, sir.
there would be a green
Dr. Saurabh, you
arrow
have any of your colleagues
there.
nearby?
Yes, sir. Yeah, I am trying.
Maybe you request your colleagues to come and help if you are charged up for the session.
Yeah, you've started screen sharing.
Looks
Very good.
perfect.
Wonderful.
Yes, sir. Thank you, Dr. Professor Nikhil. All right. Please introduce yourself, Dr. Saurabh, and please go ahead with the presentation.
Good evening, sir. I am Dr. Saurabh Joshi, General Surgery Resident from Himalayan Institute of Medical Sciences, Dehradun. And I'll be presenting a case of obstructive jaundice with ERCP-induced pancreatitis.
You can start.
Yes. So I'm presenting the case of
good to go.
I'm presenting the case of a 57-year-old male worker in a private company, resident of Almora, Uttarakhand. Patient presented to us with complaint of right upper abdominal pain for 25 days, yellowish discoloration of eyes and urine with itching for 22 days, and loss of appetite for 22 days. History of present illness. Patient was apparently well 25 days back when he complained of pain in upper abdomen, which was sudden in onset, continuous, moderate to severe in intensity, non-radiating, and aggravated after meals with no relieving factors. Patient also complained of yellowish discoloration of eyes for past 22 days, which was first noticed by family members, which gradually progressed to involve skin associated with high colored urine and itching all over the body. Patient was admitted elsewhere with above mentioned complaint, and as per patient, he underwent ERCP with stenting on the day 4 of pain. And post ERCP, patient had dull aching pain for 2 days, which gradually progressed to severe abdominal pain, which was continuous, radiating to back, associated with nausea, and which relieved on bending forward. Patient also complained of obstipation and abdominal distension on day 2 of stenting. There was gradual decrease in yellowish discoloration of eyes and itching after the stenting was done. Patient presented to our hospital post ERCP plus stenting with above mentioned complaints. There was no history of fever with chills and rigor. There was no history of jaundice in past. There was no history of waxing and waning of jaundice, any abdominal lump, hematemesis, clay-colored stools, passage of black tarry stools, or any history of blood transfusion. History of weight loss was present, which was 4 to 5 kgs in last 1 month. And also there was history of loss of appetite for last 1 month. Medical history, there is no history of COPD, hypertension, type 2 diabetes mellitus, or any chronic illness in the past. There was no significant surgical history. Personal history, patient is non-vegetarian by diet. Chronic alcohol consumption of 120 ml once in 2 to 3 days, and last intake was 1 month before the onset of symptoms. There was no history of any drug allergy. Bowel and bladder habits were normal. Patient is non-smoker, non-tobacco chewer, with normal sleep cycle. There is no history suggestive of liver disease or any other malignancies in the family members. So summarizing my case, 57-year-old male came with complaints of sudden onset, continuous right upper abdominal pain for 5 days associated with obstipation and abdominal distension for 5 days with history of ERCP and stenting 8 days back, which is suggestive of ERCP-induced acute mild pancreatitis.
Yeah,
Can
Dr.
we go
Saurabh,
back
let's
to
go
your
to first slide.
slide with the chief complaints?
Yes.
Okay, next slide.
Dr. Saurabh, I just want to ask you, you've thrown up new symptoms, obstipation, and then, but it's not there, and itching. It's not there in your presenting complaints.
No, sir.
Why?
Yeah, so you're presenting complaints and what you mentioned in the summary, they are not correlating.
They're not correlating. Did the patient have itching or not?
No, sir. Patient is not having itching currently.
So you said the patient was relieved of itching after ERCP.
So you need to describe your history of present illness in the summary, and what you mentioned about the ERCP was the treatment history that he had taken for the above complaints.
Yes, sir.
And you said obstipation. There's no obstipation anywhere. No symptoms.
Sir, he did mention about the obstipation post ERCP stenting.
But he said it was really okay. Maybe I missed it.
Yeah.
Okay,
Yes, sir, it
so
was post
you,
years.
Dr. Saurabh, look, let's get your history straightened out. 25 days back, right? He has history of loss of appetite 1 month.
Yes, sir. So since the onset of symptoms, 25 days.
No, but you've written 1 month in your
Yeah.
loss of appetite.
So in the initial history of present illness, you have mentioned specifically like 22 days, and then you are
Or
going back
25
to
days,
1
22
month.
days,
Yeah.
right? You can't be so specific in your, I mean, no patient will say कि आज से 22 दिन पहले I had this.
Loss of appetite.
It's very, the things are too specific for my liking. Okay.
Yes, sir.
Right. Next slide. So the in a, suppose it's the pain started, there was loss of there was jaundice started, and then the patient had pain, or pain followed by jaundice.
So initially patient had pain, and later it was followed by jaundice and
So what does that tell
hyperemia.
you? What does that tell you? Pain following jaundice, and what does jaundice following pain tell you? What's the difference between the two?
So jaundice, if there is initially jaundice, then it can be of maybe malignant etiology. It is progressive jaundice, which later causing pain.
No, it can be anything which is tumor. It can't. It may be malignant. It may be a lymph node. Maybe anything.
Yes.
Anything which is compressing. Pain following jaundice is usually due to stones.
Due to biliary obstruction, sir.
Yeah. So we got to get this corrected out here. You must make sure that you emphasize that there was pain and then jaundice. You get me? Let's go to your slide. Complaints of pain in right upper abdomen, sudden onset. Okay. And then jaundice. So just 3 days later, he gets jaundice.
Yes, sir.
And itching over the body. Okay. So you've written, I'm sorry, you've written itching. Okay, next slide. He went under ERCP on day 4 of pain. So the patient persisted with pain 2 days later after ERCP.
Yes, initially
What do you think
after,
was happening? What is the cause of post ERCP pain?
so it can be due to pancreatitis, ERCP induced pancreatitis.
Okay. Anything else? With obstipation, with abdominal distension. What do you think could be the other? One is
So
okay, fine.
there can be, sir, perforation during ERCP.
Right. Right. That is why it is very important that when after ERCP, you don't rush in for surgery straight away, because someone has caused a perforation, and if you do a surgery just now, it will be pinned onto you. So you got to wait. Right. This is very important here.
Yes, sir.
Okay. Okay. Next slide. Waxing and waning of jaundice. How do you take the history of waxing and waning of jaundice in 25 days? Short history, waxing and waning. You can't.
Yes, sir.
Unless there's a stone. Okay. If there's a stone which has fallen off, maybe. Hematemesis, clay colored suit, blood transfusion. Okay, next slide.
Would
But
you
you've not
like to
mentioned hemat.
would you like to describe anything about the itching?
So itching was present all over the body, and there was not any specific other association of itching.
Look, Saurabh, itching on surgical jaundice is very characteristic. What are the characteristics of itching in surgical jaundice?
So it initially occurs in the trunk region.
In the trunks, very good.
Yes, sir.
And it is there all the time. It affects the patient's sleep.
Yes,
And
sir.
there may be punctate hemorrhages when they scratch because the patient has got some coagulopathy route.
Coagulopathy.
So these are characteristics. Itching, dark stool, pale stool, and dark urine with jaundice is characteristic of surgical jaundice. No other features are more important than these four.
Yes, sir.
Okay, next slide, please.
पूछो मम्मी से
Okay, 1 month. Next slide, please. You said he used to smoke and drink, take alcohol, and he
Yes, sir.
stopped
He's an
1
alcoholic.
month before. So why did he stop taking alcohol a month before this? Any reason?
No, sir. There was no such reason. But as per patient, he stopped
Some reason?
taking alcohol
No,
1
no,
month.
no one stops taking alcohol suddenly. No one does.
Yes, sir.
Even if his wife hits him on the head, he'll not stop. He'll not stop it on his own.
How long was he taking the alcohol? You have not mentioned any duration. How
So it
many
was
years?
for past 20 years, sir.
Yeah, so
20 to
20
You
25
years
years.
and
mentioned that in
1
the
month.
history.
So he stopped taking 1 month back, but the history of taking alcohol was for past 20 to 25 years, sir.
Right. So, as a surgeon, I would like to explore why he might be having some sort of pancreatitis, some pain, some disorder to stop him from to discourage alcohol intake. Okay.
Yes, sir.
Okay. Next slide. Non-vegetarian chronic. Okay. Look, worker in a what you written working in a private firm.
Yes,
It
sir.
doesn't help you in any way. Do you get me?
Yes, sir.
If he was a worker, what kind of work was he doing? That is important. What are the things which predispose or which have a this thing for malignancy, pancreatic malignancy? Which what are the risk factors?
Uh, so for
What kind of work would
malignancy, maybe working in an industry with a vinyl chloride exposure, dioxin
yeah,
exposures.
exactly chemicals? So is he working in a
Okay.
chemical factory?
Yes, sir.
So please, anyone.
You need to revise your summary. The summary is confusing from what you have told in the history of present illness and your chief complaints. In the summary, you just mentioned about patient coming to you post ERCP. I think you need to mention there's a treatment part and not the chief what he has whatever he has presented. His chief complaints were of the right upper quadrant pain with jaundice and itching and with loss of appetite. Post treatment, he developed uh, probably pancreatitis, and his jaundice and itching, as you mentioned, has subsided. You can go ahead with the examination.
Dr. Johnson, anything you want to ask?
I think it's okay, sir. We'll proceed with the examination.
Right. I'd just like to tell you, Saurabh, before we go into examination,
Yes.
is that by your history, you have to first establish that there is jaundice. Second, the jaundice is surgical jaundice. And third, what is the cause of the jaundice? You get me?
Yes, sir.
So by your history, we are still not sure. We've got jaundice, we've got surgical jaundice, but what is the cause of jaundice? We don't know. You
Yes,
get
sir.
me? So a more thorough history would be appreciated. Right. Next slide. Go on, please.
So on examination, general examination, patient was conscious oriented, thin built and well hydrated. Vitals of the patient, pulse was 114 per minute in right radial artery with regular rhythm, good volume, and with no radial or radiofemoral delay. Blood pressure was
Saurabh,
130.
Saurabh,
Yes, sir.
ये रेडियो फेमोरल डिले कोई मतलब नहीं होता है. Do you do it in your wards? Do you do it in your OPD? You don't. Even in arterial case, we hardly do. Why do you mention all this? It will just invite questions from some examiner who's brilliant in all this kind of things and disprove your happiness. Don't do it. It
Yes.
doesn't give you, doesn't. It just invites nasty questions. No.
Blood pressure of 130/70 mmHg in supine position in right arm. Respiratory rate of 18 beats per minute and BMI of 19.2 kg per meter square. So icterus was present. Pallor could not be assessed. There was no lymphadenopathy and no stigmata of CLD or liver failure, and there was no pedal edema noted. On systemic examination, on inspection, abdomen was distended. Skin over the abdomen was normal. There were no visible scar marks and no dilated veins. Umbilicus was centrally placed and inverted. No visible peristalsis. No discoloration, striae or rashes over the abdomen. No scratch marks. No cuff impulse at hernial sites. And external genitalia were normal. On palpation, all inspectory findings were confirmed on palpation, and abdomen was afebrile on touch. It was tense, non-tender, and distended. There was no guarding or rigidity. Liver cannot be palpated due to distension. On percussion, there was no fluid thrill, no shifting dullness. Tympanic note was heard all over the quadrants of abdomen, which was suggestive of gaseous distension. And on auscultation, bowel sounds were sluggish. Per rectal examination, perianal skin was normal. There were no fissure, fistula, or any tenderness. On distal rectal examination, there was no growth felt. Glove fingers were stained with stool, and no blood stain present, and no prostatomegaly. Respiratory system, air entry was bilaterally equal with no added sounds. And central nervous system and cardiovascular system examination were within normal limits. Summarizing my case, 57-year-old male came with complaints of sudden onset continuous right upper abdominal pain for 5 days associated with obstipation and abdominal distension for 5 days with history of ERCP and stenting 8 days back. On examination, icterus and abdominal distension was present.
Okay, what's the diagnosis? What's the differential?
So on basis of examination, my provisional diagnosis will be ERCP-induced pancreatitis with it can be choledocholitis and or it can be a cholangiocarcinoma.
Dr. Saurabh, I will turn down all three of your provisionals. ERCP-induced pancreatitis is just an event.
Yes.
Choledocholitis may be. Cholangiocarcinoma is a very specific. And you said periampullary carcinoma would different. Cholangiocarcinoma is very specific, very rare. No evidence for it. Okay, let's go back to your examination. Let's see whether you can prove to me that it is ERCP-induced pancreatitis. Why should it cause jaundice before?
Jaundice is
So
preceding
previously it can be.
The ERCP happened 4 days back. How do you explain this ERCP-induced pancreatitis with jaundice?
So previously it can be a case of choledocholitis.
So Saurabh, this is not your diagnosis. It is just an event in his progress of disease.
Yes.
Right. Let's come to choledocholitis. Why do you think this is choledocholitis?
So because patient is having the pain which is likely to be a pain of biliary colic.
Agreed. That's fine.
And it was associated with features of obstructive jaundice.
Could be. Okay, good.
Yes, sir.
Why weight loss?
So basically weight loss was after the initiation of symptoms and because of not being
3 weeks.
not feeling well.
So Saurabh, 3 weeks of weight loss. How much could it be in choledocholitis?
So it was around 4 to 5
why?
kg.
Have you seen patients of choledocholitis losing so much weight in 3 weeks? Significant weight loss. So your answer would be this stones can be associated. There's malignancies. You can have stone and malignancy. Do you get me? Stone and stricture. When you put in a diagnosis, you should be ready to stand for it. Okay, cholangiocarcinoma. Why cholangiocarcinoma?
So there is painful jaundice, so maybe it can be a case of hilar cholangiocarcinoma.
So hilar cholangiocarcinomas are painful. Okay, what is periampullary carcinoma?
So periampullary carcinoma, any cancer arising within the 2 centimeter of ampulla can be periampullary carcinoma. It includes
Very good. Now, why are they taken? What are the components?
So it includes a CA head of pancreas. It includes duodenal carcinoma and so distal CBD carcinoma, or it can be a carcinoma, ampullary carcinoma.
Right. So why are all these 4 taken together? Why is CA gallbladder excluded from here?
Because so the management for periampullary carcinomas is same.
Okay, one for most of these. If suppose there is a CA gallbladder near the
Sorry, sir.
Okay, pre-related to probably water. They all present similar fashion.
Sorry, sir. You are not audible clearly, sir.
Yes, sir.
You get me? Okay, so please carry on. I'll just.
Can you go back to your examination? All right, next. So why do you say that pallor cannot be assessed in a jaundiced patient? Where will you look for pallor in a jaundiced patient?
So bulbar conjunctiva.
No, that's not true. You won't be looking for pallor there. Anywhere else you could look for pallor?
Upper palpable conjunctiva on this.
No, you would not be looking
On
for
oral
pallor in
mucosa,
the
sir.
eye. Yes, you would not be looking for pallor in the eye in a jaundiced patient.
Oral mucosa.
Next slide. Were there any visible pulsations seen on the abdomen?
No, sir.
You have not mentioned it.
In which condition we will get the pulsation?
In case of aneurysms. Or it can be in case of, sir, CLD.
Huh?
So in CLD.
And visible peristalsis?
So visible peristalsis in gastric outlet obstruction, case of gastric outlet obstruction.
What are other causes of visible peristalsis over the abdomen?
Or it can be, sir, in the transverse colonic
Transverse colonic
obstruction, sir.
Hmm?
Obstruction, sir.
What is the difference between peristalsis due to transverse colon obstruction and peristalsis due to hypertrophic pyloric stenosis?
In case of gastric outlet obstruction, there will pulsation, peristalsis will be from left to right. But in case of transverse colonic obstruction, there will peristalsis will be from right to left.
Okay.
Oh, Saurabh, I'd just like to ask you one question. Which
Yes.
type of periampullary carcinoma you'll have gastric outlet obstruction? You'll have vomiting and obstruction.
So it can occur in case of CA head of pancreas or duodenal carcinoma.
Okay. And what about hematemesis?
So hematemesis can occur in case of duodenal carcinoma, sir.
Or CA head of pancreas? What about melena?
So melena. So in case of CA head of pancreas, sir.
CA head of pancreas, why should it cause melena?
So due to sloughing or in case of
Sloughing of what? CA head of pancreas, why should there be sloughing? Sloughing of what?
Sorry, in case of, sir, ampullary carcinoma due to sloughing of tumor.
Melena only when it infiltrates into the duodenum.
Yes, sir.
Or there can be duodenal carcinoma. There can be transient melena in cases when the ampulla of Wicker sloughs out.
Yes, yes, sir.
Right? And distal CBD malignancies, they don't cause these kind of things. They don't cause obstruction until it's very late, and they don't cause either hematopoiesis or melena. So biohistory, you can find out which component of periampular carcinoma you're dealing with. Yeah. Sir, please. Dr. Johnson, sir.
Yeah, yes. I think no, the diagnosis is little still confusing, no? I'm not convinced about the diagnosis based on the clinical examination.
So you say no scratch marks, no, nothing. Everything is normal. Just go back. You said something about fluid thrill and shifting dullness.
Yes, sir.
Why did you do both the tests? Why did you do fluid thrill and shifting dullness? Both.
Sir, to check for, sir, ascites.
So if fluid thrill was positive, would shifting dullness be negative? What is the difference between fluid thrill and shifting dullness?
So fluid thrill, basically we check for in the flank region, and in shifting dullness, sir, we check it in flanks and also the central part.
Shifting dullness is for fluid in the flanks. Fluid thrill is also for shifting fluid in the flanks, is it? Fluid thrill is when the abdomen is distended with fluid.
Yes, sir. In case of gross ascites, sir.
Exactly. Your patient doesn't have, why are you doing no fluid thrill? You can't do it. Just go slide back, previous slide, please. No liver cannot be palpated due to distension. So there is so much distension that you can't palpate the liver. Can you percuss it? Was the liver percussible?
So it was palpable in the coastal region, but not in the abdomen.
So if the liver is not palpable or the liver is shrunk, what would come to your mind? in a patient who has chronic consumption of alcohol with probably pancreatitis, which
Sir,
was aggravated by your CT.
in case of cirrhosis.
Exactly. So it is important to tell us. I say your patient is having portal hypertension. He's got ascites. The
No,
liver
sir.
is shrunk. No, I am saying, prove me wrong.
So there was
Can
no
have
fluid
jaundice.
thrill. And
You're just saying, then what is the distinction about?
so it wasn't a tympanic node, sir. So it was
No,
more
no,
likely
you said
suggesting.
liver cannot be palpated due to distension. So what are the causes of distension of abdomen now? Which prevents you from palpating the liver?
So
Other
gaseous
than ascites,
distension.
what would it be?
So gaseous
It's going to be
distension
fat.
due to paralytic ileus.
Paralytic ileus. So in paralytic ileus, you can't palpate the liver. You think the gut will go over the liver. It will mask it. Saurabh, this is what I'm doing. Look, I don't know how to go, but you have to go with a clear cut agenda that this is what I have to prove. Right?
Yes.
If you find something which is not uh, what you are expecting, you have to look why are you not getting that. You can't say that liver cannot be palpated because due to distension, and they say there's no fluid, or there is paralytic ileus, maybe due to paralytic ileus. Why are you thinking of paralytic ileus with the bowels also there? Just go back. When did the last pass motion? Has your patient passed motion? Have you asked for it?
Yes, sir. Patient was having obstruction since day 2 of stenting, sir. So patient was
So
not
not
able to
passed
pass
motion.
fluids and
When
stool.
was the last time he passed motion?
So 8 days back.
So since 8 days is not passed motion, so and you're looking around for examining the patient for obstructive jaundice. My priority would be to relieve his obstruction. 8 days, massive distension of abdomen, no gas, not passing flatus, not passing motion, and no vomiting as such. Just distension 8 days. I can't believe it. Do you think that someone who's not passing motion or flatus for 8 days would you can subject him to all this kind of examination? There's something wrong somewhere. I don't know. Someone please take over.
Yeah, there's something wrong with his presentation.
Saurav,
Yes, sir.
how much quantity of fluid is required for shifting dullness, harsher dullness, puddle sign?
So approx 750 ml to 1 liter for shifting dullness, sir.
Harsher dullness, harsher shape dullness?
I don't know, sir.
Keep it in this mind because sometimes examiner will ask you.
Yeah.
Okay.
For puddle sign, it is 120 ml, sir.
And normal fluid present in abdomen? Well, these are MCQ questions. Okay, continue.
Saurabh, I'd just like to tell you, look, puddle sign 100 to 120 ml. It is inconsequential. So we've
Yes.
done away with this puddle sign and all that kind. That doesn't give you any positive input, isn't it? Do you get me, Saurabh?
Yes, sir. Yes, sir.
Yeah. So 100 to 200 ml. Sirs asked you, but it is just theory. It doesn't help you. Yeah. Shifting dullness is important because it's almost 1.5 liters of fluid. You get me?
Yes, sir.
Okay.
let's do away with all that. Let's come to your provisional diet. Let's go to your management now.
So patient had got.
No. Hang on.
Yes, sir.
What do you do? Patient had MRCP. That's fine.
Yes, sir.
You tell me what will you do now?
How would you proceed for this case now?
Yeah, how do you proceed?
So initially suspecting the case of choledocholitis, I'll go for a liver function test. And
No, your investigation, Saurabh. Your investigation will be confirm choledocholitis. And what's the best way to confirm choledocholitis?
it's MRCP.
No, ultrasound.
Ultrasound.
And if still you miss it, endoscopic ultrasound.
Endoscopic ultrasound can be done, sir.
Yeah, MRCP though is much later. Right. Okay. So you've done ultrasound?
Yes, sir.
What's your ultrasound?
Sir, ultrasound was suggestive of the microlithiasis in the gallbladder, sir.
Microlithiasis in the gallbladder. So what was the ERCP done about for? Did they extract a stone?
Sir, as per the patient, there was a stricture in the bile duct for which ERCP was done.
Okay. So now let's come to you.
What are the features?
Is there any ERCP report with the patient? What does it say? I'm just curious to know.
No, so patient doesn't have a ERCP report, but they had the report of MRCP which was done before the ERCP was done.
What did the MRCP say?
So MRCP was suggestive of.
Put on the film, yes. Good. Put on the
Put
film.
on the film. Yeah, now read the film. Saurabh, just read the film for us.
So it was suggestive of stone.
No, just read the film. If this is given to you,
yes, sir,
in the exam as a spot, how are you going to describe this?
So I can see the biliary radicals, intrahepatic biliary radicals, which are normal.
Okay. Hang on. You say this is MRCP. T2 weighted, T1 weighted.
So this is T2 weighted.
Why is it T2 weighted? Because in T2 weighted, the bile, water shines out. Bile shines out. Okay.
See, the rule of thumb is T1 is for soft tissue, T2 is for any water containing media, whether it is an MR angiography or an MR cholangiography. So it will be a T2 weighted.
H2O में 2 होता है ना? H2O में 2 होता है?
Yes, sir.
हाँ, तो T2 is water. ठीक है?
Yes, sir.
याद रहेगा?
Yes, sir.
चलो अब आगे बढ़ो. Now read. Come on, tell me.
So there can be we can see the intrahepatic biliary radicals which are not dilated. There is a in the right we can see the confluence of right and left hepatic duct, and there is some narrowing of the common bile duct.
You can't see the common bile duct at all. It's cut off at the junction. But I think the stones in the right and the left hepatic duct. Are there stones in the left hepatic duct?
Yes,
you can see the dilated intrabiliary radicals quite well. And as sir mentioned, CBD cannot be seen. The confluence seems to be formed, and stones not very clear on this. Maybe in axial images they might be more clear.
It looks like.
Okay, let's go to the report. What does the report say?
It looks like stone, sir.
Yeah, it looks like a stone.
This and this.
No.
Okay.
Yeah, go on. Read the report, please.
So there was an evidence of high-grade narrowing seen involving the common hepatic duct and the adjoining proximal common bile duct. So it was for a length of 2 centimeter and seen below the level of confluence of the right and left hepatic ducts. And moderate
No.
dilatation of proximal common hepatic duct and central and peripheral intrahepatic biliary radicals in both lobes of the liver were noted.
So now we know why you made diagnose differential of cholangiocarcinoma. See, that is a problem that sometimes occurs because if you have the diagnosis with the imaging and then you are examining and presenting the case, you get biased.
Very true. This is
Very
what
true. That's what happened.
yeah. Okay. We'll leave that. Now, okay, you've got this now. Now what do you do? Now what do you do? Saurabh, are you there?
Yes, sir.
Yeah,
Okay,
now
Saurabh,
let's
what we are asking is with this MRCP report, forget about what has been done, ERCP or anything. Patient has come fresh to you with this MRCP
This
report,
MRCP.
with
Yes.
jaundice, recent onset. What do you do now? Forget what has been done earlier.
Forget about the ERCP.
So I will get an CCT abdomen done to look for any mass.
You think there's a mass there. The ERCP is not there. You think uh, they must have given a T1 image. Look, in MRCP, if they find that there is something like this, they always do a T1 weighted image also. You get me?
Yes, sir.
Okay, so why do you want to get a CCT abdomen now?
To look for any, sir, mass.
Mass where?
So perihilar mass.
MRCP करा लिया, मरीज
Yes.
पूछेगा आपसे कि अब आप CCT क्यों कराना चाहे? बोले मास आपको MRCP नजर नहीं आया, एंडोस्कोपिक अल्ट्रासाउंड कराया?
No, sir. We will get an endoscopic ultrasound done and also take a breast cytology from the cytostricture, sir.
Okay, now we have to find out whether the stricture is malignant or benign. Now, what's the difference between a benign stricture and a malignant stricture of the bile duct, biliary tree? How did they present? What's the difference in presentation?
So biliary strictures, benign stricture can be in the distal part of the common bile duct.
No, it can happen anywhere. It's common. It may be there, but it can happen anywhere. Look, benign means it will not keep on getting worse. If the patient is getting worse, the jaundice is getting worse, if it is progressive, then it's a malignant stricture.
Yes, sir.
It's been there for a long time, just jaundice, just going on and on and on. Because benign strictures don't become so much that if they stop the bile, the patient suddenly becomes jaundice until a small stone gets stuck there, which could have happened in this patient because it's got microlithiasis. Right?
Yes.
So, okay, suppose this stricture. Now, what do you do? What have you done with this patient?
Just to clarify, would you like to get a CECT done or would you like to get some other form of CT done?
It's a triphasic CT.
Yes, a triphasic CT would be preferable because that would help you to visualize the liver as well in a better way. And you would also be able to see the ampullary region as well as the periampullary and the pancreatic head region in a better way as compared to a
Okay,
CT.
why would you like to get a triphasic? What's the difference between a triphasic CT from just a simple CCT?
So in the late, we can see for any contrast in the late venous phase, sir, involving
No,
the.
you have three phases. The first, which is before you give the dye, Then you have give the dye and then take the thing, and then you wait for the dye to wash up and you take it. These are the three phases. Okay. So
Yes,
what
sir.
does the first phase tell you? What does the second phase tell you? What does the third phase tell you?
So in the so arterial phase, will show
Okay,
that
what is the contrast? What is the contrast given in triphasic? They say double contrast. What's the double contrast? One year given IV, right? You shoot the
yes,
dye.
and
What
other
dye
one,
give, what contrast you give orally? You give water. Why don't you give an oral, say barium or whatever, or gastrographin? Because if you give any oral contrast like that, like gastrographin, it will obscure the tissues around it, right? So you have to give a neutral contrast, which is water. Okay, now tell me, पहला फेज में क्या देखते हैं, सेकंड फेज में क्या देखते हैं, थर्ड फेज में क्या देखते हैं?
so in the first case, it is basic arterial, sir, hepatic arterial.
No, first they are not the first stage. You have not given the. You just taken a CT. It is like a normal CT, CT. Okay, it's a
Yes, sir.
normal CT. You see any structural, anything which is without contrast, you can still see any tumor which is visible, right?
Yes, sir.
Once you give the arterial, what will you see? What does this artery, the arterial type give? Arterial phase,
So for the hepatic artery, flow from hepatic artery, sir.
right? Any tumor which is
Basically for
spread by the
hypervascular tumor, sir, like hepatocellular
right.
carcinoma.
Very good. And the third phase, washout
So
phase,
delayed phase. So it is washout phase, sir. Basically for confirming cholangiocarcinoma, sir.
not so cholangio. Any
In so
tumor
fibrotic, sir,
which
where
will retain,
fibrosis is occurring.
which will retain the dye inside, which will not be washed out. It will light up after everything is gone off. These fellows will still light up, like hemangiomas, like liver tumors, right? They retain the dye. So they light up after everyone is lights off in the whole city, and this fellow's house is still being lighted
Yes,
because
sir.
the fellow's retaining the dye. Okay?
Yes, sir.
Yeah. Sir, please, anyone. Dr. Nikhil, sir. Okay. So what you've
The
done
patient
now?
have a ultrasound at your center. My
Yes, sir. So we
concern for
got
this patient
ultrasound
would
done
be
at our center.
that patient has been in from North India, whether the patient has a gallbladder malignancy which is invading into the common bile duct rather than a cholangiocarcinoma. So the patient had an ultrasound from your center which showed only microlithiasis,
Yes, sir.
no
Micro.
gallbladder wall thickening. Nothing. All right, so suppose the CT shows that there is a mass in the region of the common bile duct, no liver metastasis, no peritoneal nodules, no ascites. What do you do next? Patient with obstructive jaundice with a stricture of the mid CBD or the common hepatic duct.
So we can go for EUS, sir, endoscopic ultrasound, and can take a biopsy from the lesion, sir.
All right. So if what do you want to see in the biopsy?
So to look for the malignancy, whether it is a benign or malignant stricture, sir.
And any other way that you can take a biopsy from the common bile duct? You can do an endoscopic brushing. That is
Endoscopic,
a
yes.
brush biopsy, although the yield is low.
Yes. So we can go for mother baby endoscopy also, sir.
But the yield during these biopsies is lower compared to the conventional biopsies. So you have to go on your imaging
We can go.
findings a lot of the times. All right, so your biopsy shows a malignancy. Now what do you do? What's your next plan going to be?
Sir, it can be a case if it is a cholangiocarcinoma. We can look for first of all, sir, surgical, if whether it is resectable or not, sir. We can go for pre-operative biliary drainage, sir. So we will
Why would
confirm,
you?
sir. Yes, sir.
Why? What is the advantage of preoperative biliary drainage? What is the disadvantage of preoperative biliary drainage?
So pre-operative biliary drainage, it can be a source of infection, sir.
Okay.
And so lowering the level of bilirubin reduces the
So it
chance
will
of
cause periductal fibrosis. It will make your dissection difficult.
yes.
If the lesion appears resectable on your imaging, better to proceed for surgery. What surgery will you plan?
So it will be depending upon the involvement with bismuth chloride classification, sir. If it is type 1, which is involving below the level of confidence, we will go
What is that
directly.
classification?
Yes, sir. Sorry, sir.
So, what is that classification? Tell me.
Yes, sir.
Bismuth classification.
So type 1 is involving the below the level of confidence. So type 2 is up to the level of confidence. 3A is the involvement of right hepatic duct. 3B is the involvement of left hepatic duct. And type 4 is involving both the hepatic ducts and below.
What are the
Okay, so
complications of the biliary strictures? Complications of the biliary strictures.
Short-term complication and long-term complication.
Biliary strictures are they can lead to in long
Immediate
it can cause acute cholecystitis, cholangitis. Sorry, sir. It can cause cholangitis. It can cause
and in long term,
biliary cirrhosis can occur, sir.
secondary biliary cirrhosis.
Secondary biliary cirrhosis.
Primary, secondary, secondary biliary. And one more.
And cholangiocarcinoma, sir.
Portal hypertension. Portal hypertension.
Portal hypertension. So it can lead to liver abscess can occur.
What are the disadvantage or risk of the PTC? Saurabh?
Yes, sir.
risk of PTC
What are the
procedure.
disadvantage or risks of the PTC?
So it can cause hemorrhage. Bile leak can occur, sir.
Okay, bile leak, hemorrhage.
So it can
It
also
may
lead to
precipitate
pneumothorax.
cholangitis. It may precipitate
So it
septicemia,
can
not
cause
pneumothorax.
sepsis.
Bile leak, hemorrhage,
So pneumothorax can occur.
cholangitis, or septicemia.
What are the advantages of doing a preoperative biliary drainage?
So it can reduce the chances of post-operative shock in patients.
What kind of shock are you talking about?
So basically, it is hypovolemic shock, sir.
How would preoperative
In
bleeding
biliary
help you in
sepsis.
preventing hypovolemic shock?
So because increased bile level
In
can
biliary pterygium,
yes, sir.
hypovolemic shock or septic shock. We'll get
Septic
in.
shock. Sorry, sir. Septic shock. Sir, preoperative drainage can help in sir reducing the. It will improve the coagulation profile of the patient, sir, and
Okay.
it can recover the liver function, sir, so that synthetic functions of liver can be recovered, sir.
Which includes coagulation and what are the synthetic functions of liver?
So, bile synthesis, sir, oxidation of, sir, toxic
Which
metabolites,
protein
sir.
is synthesized from liver?
Albumin, sir.
Yes.
Albumin
So your
synthesis.
nutrition will definitely improve once you do a preoperative bleed drainage. Any other function do you expect improvement post biliary drainage? Or something which you can again prevent by doing a biliary drainage?
Sir, renal impairment can be, or sir,
Yes.
immune and barrier
Yes.
immunity.
Renal function is significantly improved if you do a preoperative biliary drainage. But as Dr. Nikhil mentioned that, sir mentioned that it will make your surgery a little difficult, dissection will be difficult due to periductal fibrosis. And also preoperative drainage is required in case you're planning for a neoadjuvant chemotherapy for like carcinoma gallbladder with jaundice.
Yes.
So this what surgery would you do for this type of stricture as being mentioned in their MRCP? Say it is bismuth type 1.
So we can go for sir resection of extrahepatic bile ducts with taking the margins 0.5 to 1 mm of margin, sir, and then hepaticojejunostomy.
And suppose the stricture was at the lower end?
So then we will go for sir pancreaticoduodenectomy, sir, Whipple's procedure.
Dr. Johnson, sir?
If it is a distal cholangiocarcinoma, you will go for Whipple resection.
Yes, sir.
So, have you assisted Whipple's procedure?
No, sir.
So, you know any important surgical steps of Whipple's procedure?
So we go for sir resection of head of pancreas, duodenum, and sir.
What is the first step you will do after laparotomy? We put a bilateral subcostal incision, went inside. First step, what you will do?
Dr. Saurabh, it is very, very simple. You please tell what your department does it.
Yeah, what your
Not
department?
on opening, you will do operative staging. What all you look for? That is all. It is not very complicated. Sir is asking very straight and simple question. On planning for a Whipple, what all you look for on entering the abdomen? You sequentially tell what you normally do in your ward. That is all is the
Yes,
answer
sir.
he is expecting.
Yeah, that's all.
So first of all, sir, we will go for sir cauterization of the duodenum.
First is cauterization.
Dr.
So first
Saurabh,
of all,
you
yes.
do operative staging first, then you start dissecting. No, so tell about the intraoperative staging
So first of
process once you
all,
enter the abdomen.
we will go for exploration to look for any metastasis, sir, or
Yes.
any in the liver or peritoneum,
Okay.
and
Okay.
also to look for omental deposits, where whether we can proceed for surgery or not, sir.
Okay.
So then we will go for mobilization of duodenum, cauterization.
Before that, that's not the first step, no? You have to take down the hepatic flexure of the colon, no? That is called cattle brush maneuver.
Yes, sir.
Will you do that or no?
Yes, sir, so that we can easily mobilize.
Okay, and then next step is once you take down the hepatic flexure of the colon, then next step will be
So
cauterization.
Cauterization, sir.
Okay, how do you do that?
So we will move
Mobilize the
duodenum.
which part?
So for second part of duodenum, sir.
Okay, by dividing.
So dividing it posteriorly.
What is the
Laterally.
fascia called? Laterally. So once you cauterize it, you know what you will see the structure underlying. What is the venous structure you will see?
So inferior vena cava.
Okay.
Major blood vessel, sir. Inferior vena cava, left renal vein.
Okay. Then you mobilize still more. Extended cauterization. Then you will visualize the another vein will be there, no?
Sir, in left renal vein, sir.
Yeah. So that's called extended cauterization. Till that you have to mobilize.
Yes, sir.
Okay, you are mobilized now. You assess the tumor now
Yes, sir.
by palpation. Okay, so whether it's a periambular tumor or a carcinoma head of the pancreas, whether it is resectable, then you can have a SMA first approach to assess the resectability, whether there is any vascular involvement of the superior mesenteric vein or the superior mesenteric artery.
Yes.
Once you are sure that there is no vascular involvement, then next step what you will do?
So then we will go for dissection. Gallbladder. So we will divide the gallbladder and the bile duct, sir. After that.
No. Before that, you have to create the retropancreatic portal tunnel, no? Then only you are sure that it is resectable.
Yes, sir.
So how do you create that? Retropancreatic portal tunnel, how will you create? You dissect along the lower border of the neck of the pancreas. You create a tunnel between the anterior surface of the superior mesenteric vein and the under surface of the neck of the pancreas. And this plane is a vascular plane or the avascular plane?
So vascular planes.
So
vascular.
Vascular. What are the veins and the arteries you encounter in this tunnel? I think you have not seen the portal tunnel is avascular, no? God has created. That is why we are able to do that, people.
Yes.
So it's avascular. Okay. Then next step, you have created the tunnel along the upper border of the body of the pancreas. What you will dissect? What is the lymph node you encounter there? Along the upper border. What is the vessel you encounter along the upper border of the body of the pancreas?
The splenic artery.
Splenic artery very distal, no? Still proximal, little proximal. Common hepatic artery. So what is the lymph node lying on top of the common hepatic artery? So you have to dissect that hepatic artery lymph node to visualize the underlying common hepatic artery. Okay, once you dissected the common hepatic artery, then you dissect the
Gallbladder, sir.
no. Next artery will be what? What is the next artery coming from the genu of the common hepatic artery? What is genu of the common hepatic artery? There will be trifurcation, no? What is a trifurcation? Where all the pancreatic surgeons are very particular. So from where the common hepatic comes? Origin?
From the celiac trunk, sir.
Okay, you trace the common hepatic artery, then it enters into the hepatoduodenal ligament, no?
Yes, sir.
Before that, it gives a branch downwards to the pancreas. What is that artery? Gastroduodenal?
Gastroduodenal artery, sir.
Okay, so that is a trifurcation. Okay. After it gives, it becomes the hepatic artery proper. So what you will do at the level of, once you dissected the gastroduodenal artery, before ligating, what you will do? Do you any maneuver? Or just ligate and divide it? Do you do trial clamp test?
I don't know. No idea.
No idea. So you have to do a trial clamp test before dividing the gastroduodenal artery because you want to confirm the liver perfusion, no? There is any arterial anomalies. Any arterial anomalies, you know? Where most of the pancreatic surgeons are interested. Any arterial anomaly, common anomalies. Aberrant or accessory right hepatic artery.
Sir
Then let
Johnson,
me
sir,
know.
maybe you can give him a teaching module as steps, sir. Then I think he finds difficult, sir.
Yeah, that's why I'm giving
No,
clues. Okay, so
you can teach
these are
him,
the
sir. The important steps you please teach him,
yeah,
sir.
because
Then
yeah. So once you divided the gastroduodenal artery, you can have the portal tunnel both in the upper border and the inferior border. Then you are ready to transect the neck of the pancreas.
Yes, sir.
Okay. So now neck of the pancreas is also divided. Now you are in the point of no return. Now you have to complete the procedure. Then you divide now dissect the hepatoduodenal ligament. You skeletonize all the bile duct, hepatic artery, and the portal vein by removing all the fibrolymphatic tissue and the lymph nodes. So completely remove all the lymphatic tissues. Once the hepatoduodenal ligament dissection is completed, then you come for the jejunal, then gastric transection. Jejunal transection should be 10 centimeters from the DJ flexure. And then you dissect the gallbladder also in the meantime. Then you transect the common bile duct above the cystic duct entry. You know why? Why you should transect the bile duct above the level of the cystic duct entry? Any idea? Okay. I think you have to read still more regarding surgical procedures. So once you transect the common bile duct above the cystic duct entry, then specimen is what are the parts to be resected in Whipple's procedure?
Yes, sir.
Finally, distal
Sir, head of pancreas.
head of pancreas, entire duodenum.
Entire duodenum, sir, common bile duct, gallbladder.
Okay.
And
distal stomach, you were told?
distal stomach, sir.
Okay. So what are the types of Whipple's procedure you know?
No, sir.
Classical, modified,
No, sir.
pylorus preserving, pylorus resecting. So you should learn, I think, all these things. So what are the 3 anastomosis you do following Whipple resection? Any idea?
So we go for hepaticojejunostomy,
Okay, good.
jejunojejunostomy.
No, first is pancreatico jejunostomy, then hepatic jejunostomy, then gastrojejunostomy. Then we'll go for feeding jejunostomy or nasojejunal tube feeding for the enteral nutrition.
Yes.
Enteral feeding purpose. Okay, good. And your attempt is good. So
Thank you,
anything
sir.
they want from us?
No, no, sir. Please finish. Please finish. Go ahead and finish.
Anything you want? Saurabh, you have any doubts?
No, thank you, sir.
Regarding the surgical procedure and the anastomosis?
No, sir.
Saurabh, you today only go and read the steps of the procedure and read the
Definitely they will
textbook,
ask in the exam, yeah.
right? You
Yes,
should be
sir.
aware of the steps. It's not that you should be capable of doing, but then you should be knowing the steps that will be definitely asked. Professor
Saurabh.
Nikhil, Professor Nitish, sir, Rajiv, sir, other seniors, would you like to ask any doubts, sir? Questions rather, sorry.
Saurabh,
No, I think he's
what are the
done well.
complications of the Whipple's operation?
So there can be an
Sorry.
anastomotic leak.
Okay.
Saurabh, you anytime when somebody is
Delayed
asking a
gastric empty.
complication, you categorize them to on-table complications, immediate perioperative complications, and long-term complication. No, you have a system, not only for Whipple's operation, any surgery for the matter,
Any
you
major
have this system that you will not miss out on anything. Then you should be able to stratify which are the most common challenges during the surgery. And then something can be rectified, something cannot be rectified. They end up doing a full resectional procedure where they may recommend to do a total pancreatectomy also. So unless you know what are the challenges of doing, when you have challenges like very soft pancreas, you're not able to take anything, not able to dunk, or vessels unfavorable, patient is very sick on the table, many parameters come. So you should get back. Post-operative pancreatic fistula will be a separate short note for you. And last year, there was a major update in the subclassification.
Yes,
The
yes.
subtypes have been upgraded. And more and more, they are also orienting towards a step-up approach. Earlier, they used to be aggressively managing. Now, earlier detection by way of doing a tube and serum amylase ratios and other things have been recommended before even patient becomes symptomatic. You don't wait for 500 ml, 1000 ml of fluid to come out through the pancreatic drain. So please go back and read. Any other faculty, would you like to give your comments before we call a close, please? Do you have any doubts, Saurabh? Dr. Nikhil, sir, please.
Got biased a little by the reports that the patient had.
Yeah, that's
So
what.
whenever you are appearing or seeing a case, you keep your eyes and ears open. Don't get biased by the reports. Reports are the last thing that you want to see. And when you're presenting, present it as a de novo case. Don't go by what the reports are saying.
That is
And
what I
don't
think.
try to fit in your findings into the reports and tailor your findings according to the diagnosis that you already have.
Yes,
But
sir.
you have attempted this well and wish you all the best.
Yeah, wish you all the
Thank you,
best.
sir. Thank you, sir.
Rajesh, sir, anyone else? Sir?
No, that's fine. I think it's done well. It's first of all, it's
Kanna,
very
sir?
difficult to present on an on a national platform. He's done that well.
True.
Secondly, there has to be you have to present more in your hospital so that there is more clarity and you plan out how
Yes,
you present your case. That is very important. How to approach a case,
yes.
right? So you have to sit and think. What do I do to prove my point or to come to a diagnosis? But otherwise, done well. Well done, Saurabh.
Yeah, well done, sir.
Presentation, Saurabh.
Thank you, sir.
Oh, thank you, sir. Thank you all esteemed faculty for staying late in the night to complete the presentation. So we'll meet another Friday for with yet another case. I thank the newer faculty, Professor Talwar sir, Professor Tarun Kalra, and others who have joined recently. With us, sir, these programs happen on a Friday basis, which has been happening for the past 6 years. So please feel free to join us anytime you wish. This is a sort of an open platform only. So don't feel like bad or embarrassed to join us anytime. And I also recommend your PGs may be kindly permitted to this platform. There is no commercial interest in this. This is all the cases which have been discussed, all the 590 cases so far we have discussed, which is available free for all in the platform. Anybody are welcome to go through and learn out of it. So thank you once again for all faculty and students for contributing this for the every week Friday PG class. Thank you very much. And faculty, any other comments? Can we call a close for this evening session?
Yes, sir.
Yeah, good night.
Yes, please. Thank you.
Yeah.
Yes, sir.
Thank you very much. Thank you, sir. Thank you very much.
you.
Thank you, everyone. Good night,
Thank you.
everyone.